Dr. Marks, Dr. Bianco. It's a pleasure to be here, setting up a program. The secret sauce. You need to know this. There's no secret ingredient. It's just hard work. I mentioned that earlier. For any of those Kung Fu Panda fans or have young kids, this is for you. So just hard work and a great team. This is not going to be something that you can do on your own. I've really spent a lot of time, and I keep telling you, it's not that I'm special. It's just the time and resources of working with people. Radiology, I really recommend the better imaging you have. People are like, what? It's just diagnostic. In focal therapy, the best images will keep you from missing other tumors. Dr. Emberton has excellent results. Other people, well, you can't achieve that. But it's really the quality of the MR and their interpretations. Fusion biopsy, you can choose your modality. You can pick whichever one you feel more comfortable on the workflow. Same thing with the modalities, but you should develop a toolbox that allows you to treat the entire prostate. And I think it should always be a closed loop system. You always have to have the feedback, and we talk about that a lot because we have to learn from our mistakes. Everyone here has struggled and achieved what they have today by working through their mistakes and learning from them. So hopefully you remember the rule of the house of God. It's okay to make mistakes, just don't make a bunch on the same patient. So garbage in, garbage out. We move through this, you hear this, we've been saying this for a decade. The platform and goes to how do we do the feedback? Because the garbage out. And I really, really want people to start recording their cases to learn how to get better at this. Because guess what? Focal now, you're going to start blaming the modality. How many people feel that the surgeon always blames his tools, not himself? Not one hand? Come on, guys. But that's one of those things today. Imaging, dedicated imaging team. You need to have it. If you choose and you send your patients to different places, even if you're in private practice, pick one guy you like, pick one place you like, and cultivate that relationship. The CAD systems, they're really important because that gives you the feedback and to store the data. And if you're unsure, and I talked about this yesterday, use the PIRADS document to force people to do high quality imaging at the end of the day. Very easy and straightforward. Treatment planning, I showed this in my lunch talk. How do we use the information? And then visualize your approach. Understand where you are, what you're doing, identify your critical structures. It seems simple enough, but when you put it to practice, I think it really has a lot of benefits. I talked about using the information to navigate the pelvis, that people are uncomfortable. Don't set up your whole case and realize there's bone in the way of your needle. And how many people do focal therapy or transperineal biopsies and end up realizing there's bone in the way if you have a transperineal approach? It happens, right? I work for my lateral in. We all make those mistakes, but you have to make them at least once. I showed this in the prior lecture. This is just the idea that I marked the external sphincter in blue here in the relation to the prostate. I'm able to stick my cryoprobe into the lesion plus the margin that I created and create the ablation zone. And this is what we see after the fact. It just helps you understand where things are so you avoid maybe non-target treatment. Because organs of risk are the really things that get us here. And if one point I want to make, the nerves go like this and up, right, guys? If you pull your ice ball when you're doing a posterior tumor too far and get into this zone here, you're going to take out the nerves while you think you're doing a great job. So be aware of that. So again, there's no secret ingredients except a great digital designer for the Focal Therapy Society logo. Image review. Fusion biopsy review, you need to take this every step of the way. Your treatment planning, review your case, review your pathology, and talk about missed cases and recurrences. And currently in the United States, the FDA, for all approval of new devices and outcomes, are looking to get a tissue diagnosis at 6 to 12 months. It's important to understand that. In the future, we're going to probably go to image-based, like every other cancer in the body, use imaging as our surrogate for tissue assessment. But for right now, for prostate, due to its multifocality and the being a new emerging field, we're getting tissue to reinforce that we're actually killing what we say we are. Thank you.
Thank you, Art.